Hello everyone, I'm Dr. Sabrina Bra and welcome again to the Better Breathing Institute webinar series. This will actually be our last webinar before we take a short summer break, but if you do want to catch up with any of our previous expert-led webinars, you can watch them on demand on our webpage or YouTube channel. Today it gives me great pleasure to welcome not one but two experts in respiratory physiology and clinical practice, who will be exploring the science and application of breathing pattern assessment, breathing retraining, and targeted inspiratory muscle training. Whether you work with athletes pushing physiological limits or patients managing chronic respiratory conditions, this session should give you the evidence-based tools so that you can apply it immediately in your day-to-day practice. Professor John Dickinson is one of the UK's foremost experts in respiratory health, working extensively with elite athletes, with a particular focus on exercise-induced bronchoconstriction, airway dysfunction, and breathing pattern disorders in sport. Kris Bahadur is a physiotherapist and doctoral researcher whose clinical and academic work sits at the intersection of musculoskeletal physiotherapy and respiratory science. With hands-on experience working with both clinical populations and in performance settings, Kris brings a practical lens to the evidence. So without further ado, I will hand over to both of our speakers. There will, as always, be an opportunity for questions at the end of today's webinar. Over to you to John and Kris. Thank you.
Fantastic. Thanks for the lovely introduction and hello to everybody listening in. So my name's John and this is Kris. I'm just going to take the first 15 minutes or so to kind of introduce breathing pattern and breathing pattern training. And then Kris is going to kind of take it on and go a bit more kind of into the breathing pattern training and sort of technique with inspiratory muscle training. And hopefully we'll have plenty of time for questions at the end. So what we're hoping we can kind of give you a little bit of in this session is we'll be hoping you can understand what an efficient and inefficient breathing pattern is, understand how breathing patterns may impact physical activity and exercise performance, and also understand how breathing pattern can be optimized during respiratory muscle training. So the first part, we kind of hear this kind of term breathing pattern kind of banded about quite a lot. But what actually are we referring to when we're talking about a breathing pattern? And I think it kind of comes down to kind of these main constructs. The first one is kind of respiratory rate, and that is kind of around kind of obviously how many times you're breathing per breath. And there's probably still not a fully agreed number on that, but I'd probably say somewhere around 12, somewhere between 8 to 12 breaths at rest. But then into exercise, obviously respiratory rate can increase up to kind of 40 or 50 times per minute. So that's one aspect of breathing pattern. Another aspect is tidal volume, which essentially is the amount of air that you ventilate per breath, which when we're kind of at a rested level, depending on how big we are, we're breathing at approximately half a litre per minute. Per breath. So our tidal volume is about half a litre. Whereas if we're exercising, it can kind of raise up to 3 or 4 litres, depending on how big the person is who's exercising. So tidal volume is another aspect. And then we've got the rhythm. So kind of how smooth, cyclical, or continuous is it? Are there any kind of breath holds in it? Are there any are there any kind of pauses mid-breath, those sort of things that we might be looking at either in the inhalation or exhalation. Another part is the mechanics about in terms of kind of how do the respiratory muscles and the diaphragm move and how is that all coordinated. A lot of the time when we think about our breathing pattern, we hear a lot of people talk about diaphragmatic breathing, which is great because our diaphragm is our biggest breathing muscle. It's not our only breathing muscle though. There's another 64 breathing muscles that we need to coordinate when we breathe. So it's not just about diaphragmatic breathing per se. It's also about the coordination of the other 65. And obviously we might not need to use all 65 in various parts of our day, but at some point if we're working harder, doing higher intensity exercise, we might start to recruit more of those 65 muscles. And how do we do that? And then we've also got the neural kind of respiratory drive to this as well, where the primary rhythm is generated by the brainstem. But the autonomic nervous system is constantly altering this pattern to match what we need. And we've got our kind of sympathetic system, which is kind of our breathing accelerator, when we need to kind of speed up our respiratory rate and tidal volume. And then we've got the parasympathetic system, which is kind of our breathing brake, where we maybe need to slow down and control that kind of respiratory rate and bring that respiratory rate down, and maybe slightly might even increase the tidal volume to a touch just to help bring your respiratory rate down, but making sure that that rhythm is nice and smooth and relaxed and calm. So there's lots of things that can kind of impact their breathing pattern that I've just sort of talked through there. Now, just to add some more complexity to it, and I'm not going to go through this slide too in depthly, but what I really want to get you think about when we think about breathing pattern, that breathing is it's a bidirectional closed loop system, i.e., that there's several physiological systems that feed in to your respiratory center and ultimately impact your breathing pattern. And then your breathing pattern, how it responds to that, will then impact those six systems again. So if we've got a nice kind of I refer to as a healthy breathing pattern, that usually kind of promotes kind of a healthy function within the body. But if our breathing pattern starts to become dysfunctional in any way, so we start to maybe hyperventilate, or we start to get an inadequate tidal volume, or our rhythm starts to get lost in terms of we start to maybe be a bit jerky in the way we move our rib cage and things, that can then kind of have some more negative effects on these systems, which then starts to kind of have knock-on effects in terms of kind of how much physical activity and how much exercise that we can do. And people who are experiencing this might start to limit their level of physical activity based upon their kind of sensations from their breathing. So breathing is very complex. A lot of the people I initially meet when I I work with breathing pattern, and they go, "Oh, you're just working on people breathing in and breathing out." And I go, "Yeah," but then we talk about how complex it is, and then we kind of, then we start to actually kind of make it, make sense why this is an emerging and quite difficult to kind of grasp kind of area, because it's quite complex to measure kind of what is causing changes in breathing pattern, because obviously you can see the six systems I've listed there. And obviously those systems have lots of kind of multiple factorial things going on inside them. So when I kind of ask this question, kind of what is a good breathing pattern? And usually if I'm in a live room, I'll kind of ask people to put their hands up and say, well, who's been taught how to breathe? And most of the responses, everyone kind of scratches their head and goes, well, I wasn't really taught how to breathe. I just was born, I started breathing and kept doing it. And so what we tend to sort of suggest with breathing pattern is everyone kind of finds their way of moving their rib cage in their own unique sort of style. And just like your walking gait, everyone's kind of got their own unique walking gait. And some people's breathing pattern is really healthy and really efficient. Other people's is adequate in terms of it allows them to kind of get around most of their daily activities without kind of impinging on them. Other people's it starts to fall into a dysfunctional kind of breathing pattern where it starts to limit activity. And for some people, that might be during the top end of high intensity exercise. For other people, it might be simply getting out of a chair or walking up the stairs can be impactful. So having an efficient breathing pattern is really important, but being aware of that breathing pattern and using that breathing pattern when we're doing things like respiratory muscle training is also really important as well, which we'll kind of move on to. But this kind of question, what is a good breathing pattern? It's kind of something I asked kind of myself around about 25 years ago when I was first working with the British Olympic team, because we had a lot of athletes who were demonstrating signs of breathlessness, but we couldn't find a diagnosis of asthma with them, so it wasn't asthma causing it, and there was no kind of other cardiovascular issue that was sort of would be the underlying cause of it. And then we started to think, well, actually, maybe is it the way these athletes are trying to breathe? Is it their actual breathing pattern mechanically? How are they moving their rib cage? That's causing it. So that's kind of led me down a line of kind of the last 10 years of delivering various research projects that have looked at kind of biomechanically, how does the rib cage move with a good breath and with a less efficient breath, which is kind of where these kind of studies come from. So we've got several studies, and effectively they all center around this technique called optoelectronic plethysmography, which is the last time I'm going to say that word. We'll call it OEP for now. And effectively, what it is, it's a 3D motion capture system where we've got kind of 90 markers stuck around the torso. And we've got a 3D motion capture system that's effectively picking up the movement of those markers. Now, from that, we can generate these 3D models that you can see in the bottom right-hand corner of the screen, which we can kind of use to kind of track the movement of the rib cage, either at rest or during exercise. Now, from this technique, we can measure things like tidal volumes and respiratory rate from that. But we can also look at kind of the movement in different compartments of the torso to look at how much movement occurs in the abdomen and how much movement occurs in the rib cage, for example, in the middle figure here, how much of that movement contributes to the breath. And then what's really interesting in terms of breathing pattern is we can look at different segments of that torso and look at, are they moving together, or is one compartment moving at a different time to another, which is what we have on the right hand side here, where we kind of have the abdomen compartment. So basically, or in your torso, everything below your rib cage versus your rib cage itself. Does it move together, or does it move at different times? Now, what we found in kind of healthy breathing, so this is kind of an example of one of our testing setups, is what we found in healthy breathing is if we look at the figure right in the middle of the page here, where we've got kind of, it says phase angle on the top, and you look at rib cage volume and abdomen volume. As that graph moves left to right, that's when someone breathes in, and as the graph moves right to left, that's when someone breathes out. Now, basically what this is showing us is that as abdomen volume increases as you breathe in, rib cage volume increases because we're getting around about a 45-degree angle on the way in and around about 45-degree angle on the way out, which basically tells us that parts of the segment of the abdomen and parts of the segment of the rib cage are moving together, or what we like to call in synchronization, throughout the whole of the breath in and throughout the whole of the breath out. So there's not a period of time in a healthy breath where the rib cage or the abdomen is moving in isolation. It's basically what our kind of research demonstrates. Now, if we look at somebody who's got what we kind of define as a breathing pattern disorder, and we look at their breathing at rest, this is kind of a deviation away from that kind of 45-degree angle, where if you look at the phase angle graph again, you'll see the abdomen will be coming out. So the abdomen is moving first because the graphs kind of go moving kind of flatly along the right hand side. And then once the abdomen stops moving, the rib cage rises up, which is why we see a line go straight up halfway through the breath. And then when this person breathes out, the abdomen moves first, and then the rib cage moves second. And then when this person exercises, they do the same thing, but just faster. And what we know when we kind of do this type of research and we identify these changes is people that breathe like this, they breathe less air per breath, so their tidal volume is reduced. They breathe more air, or so they breathe more times per minute, which means they're likely putting more energy into their breathing. And they report more respiratory symptoms like breathlessness, higher dyspnea scores, and they usually either stop or slow down their exercise because of their breathing rather than because of the usual effects of fatigue from exercise. So this basically, an abnormal breathing pattern can be quite impactful. But there's lots of funky ways of breathing inappropriately. And so we need to kind of make sure that when we're working with when we're working with individuals, and when, in particular working with respiratory muscle training, that they're not adopting these poor breathing patterns, because if they're training a poor breathing pattern, then it might then lead to a poor outcome. So just to sort of summarize what a kind of healthy breathing pattern is based on this research, is we've got, if we kind of think about the different kind of colors in the figure on the left hand side, just to identify them to you. So you've got kind of the greeny area is kind of the bottom of the rib cage, and you think about that's kind of where the diaphragm sits. And then we've got the blue area, which is the rest of the rib cage, and we've got the orange area, which is your abdomen. Now, if we were going to kind of summarize where does a healthy breath start from in a healthy breathing pattern, the breath starts with movement in the lower rib cage, so in that green area. And in a healthy breathing pattern, the green area initially moves kind of sideways. So we get a bit of sideways movement in the bottom of the rib cage. And then it moves kind of smoothly into a forwards and backwards motion in that kind of green area. And if we're just breathing at rest, pretty much all it needs to move. Whereas when we start to exercise and we need to get a larger, tighter volume, we start to get greater expansion in that rib cage, which means that that initial sideways and forwards and backward movement in the green area kind of then just radiates into the kind of blue area and more into the orange area. So that expansion continues to become nice and smooth. And then when we breathe out, we just get that recoil of the chest wall, relaxation of the inspiratory muscles, and the chest wall kind of recoils. And we get a nice smooth kind of recoil of the rib cage back to kind of an appropriate point where we've exhaled enough air out that we can kind of repeat the breath. The exhale is also really important as well. So when we think about the exhale, if the exhale is too fast, that can excite parts of our nervous system, like the sympathetic nervous system, that might start to lead into a poor breathing pattern as well. So we know the exhalation needs to rely on the recoil of the chest wall rather than overly forcing out the air. And also the exhale needs to the person needs to maintain their kind of posture. Whereas if they're breathing out and kind of closing and dipping down as they breathe out, that kind of puts them in a poor posture, which makes it quite difficult to expand the rib cage in an appropriate way. So we need to kind of be aware of what's going on. Now the question is, just going back a slide, is if you've got a poor breathing pattern, can you improve it to make it into a better breathing pattern? So I'll just show you an example of an athlete who has a poor breathing pattern. And you just sort of see how debilitating it looks and feels for her. Brilliant. You stand up for me. You stand up and just look straight, stand still and look straight ahead. So she's moving her rib cage and her abdomen at different times. So stay there, keep looking straight ahead. Struggling to get a decent breath in. You see she's relatively quite distressed, and she's basically reporting that when she does her 800-meter training, that she can only really do about a lap of the track, and that was her kind of her session done, really. And we tested her for all the respiratory issues, and that was all coming back negative. So there was no asthma kind of contributing to this, and there was no other cardiovascular issues either. So then when we kind of sort of supported her in improving her breathing pattern, which I'll go through in a moment, we can see changes to her breathing pattern. That's it. Cool. Can you just stand up for us? Just look dead straight forward. You just pull your shirt tight if you can, just so I can see it. That's it. You can see here she's much less distressed with her breathing. Postural control is much better. Coordination between chest and abdomen, very good. And we can see some lateral movement in the lower portion of the rib cage, which allows her to expand that rib cage better, so therefore get a better quality breath. Yeah. So when doing kind of breathing, you just stand up for us. We want to kind of emphasize. Look, that's straightforward. Just pull your shirt tight if you can. Kind of movement around, kind of good postural control, synchronization between the chest and the abdomen movement, and kind of initiating the breath with the lower rib cage. And ideally a lateral movement, but at least the lower rib cage is kind of where you want that breath to start from. Okay. So kind of things when we're kind of considerations when we're thinking about what can affect breathing pattern, we need to kind of make sure when we're doing respiratory muscle training, as well as much as doing breathing pattern training, we need to make sure the technique is a good technique, just like any other kind of muscle training. We need to make sure the technique is sound. We need to make sure that the postural control is good. We need to make sure we're kind of managing the kind of stress and psychological sides around breathing pattern. And then we need to kind of be aware of kind of environments and lifestyle factors that might also impact it. So basically, within kind of when I work with athletes and other people helping them retrain their breathing pattern, if they do have a disordered breath, these are kind of the different things that we might use. Now, what I'm going to kind of just highlight here is because Chris is going to go on to talk about it in a minute, is the use of inspiratory muscle training within this pathway. And I find inspiratory muscle training really helpful to promote a good breathing pattern, but it needs to be delivered within the context of making sure the individual understands what a good breathing pattern is first, and then understands how their kind of postural control might impact their breathing pattern. And then we can kind of look to bring in the inspiratory muscle training. Now, around about 20 years ago now, I kind of worked with an athlete and we used inspiratory muscle training with an athlete in the build up to the 2004 Athens Olympic Games. Um, and we published this as a kind of a case study in the British Journal of Sports Medicine. And basically, what I wanted to highlight here is that the inspirational training was really impactful for an individual with a breathing pattern disorder. She had a specific breathing pattern disorder that was linked to an inspiratory stridor. Um, Now, she basically conducted kind of a POWERbreathe program for sort of 11 weeks. I sort of focused around 30 breaths at around about 50% of her maximum inspiratory mouth pressure. And what we found was when we did all this that her inspiratory muscle strength improved. Now this is quite interesting. This is probably where the research needs to go is I'm not quite sure whether she improved that solely down to the IMT or partially because we improved her breathing pattern. So the way she was coordinating her inspiratory maneuver was also improved. So whether it's purely down to an improvement in kind of ultimate strength of the actual respiratory muscle, or whether it was actually improvement in the coordination as well. It's likely to be improvement in the coordination as much as development in muscle tone as well. We saw an improvement in their ability to recover from repeated sprints, and we saw a massive improvement in the amount of respiratory symptoms she reported during exercise. So from this kind of early work, we really kind of the respiratory muscle training had a massive place to play. But one of the things that just kind of I probably try and tease out that maybe doesn't come out in this case study is around the edges of the case study. There was a lot of work done with her around her breathing pattern as well. So we really focused on when she was using the POWERbreathe device that she was using, that we really focused on technique. So making sure that she had a smooth technique, making sure the breath started from the lower rib cage. It's a powerful movement still, but it was a powerful movement generated from the lower rib cage movement initially, that then kind of then expanded into the upper rib cage. The breath was smooth, and then the breath out was nice and relaxed. And then that allowed us to kind of develop this kind of more positive breathing pattern and then allowed the athlete to go and then train however she wanted to go on and train. And then she went kind of from being a contender for a final, and she actually managed to get herself a bronze medal. So she actually was able to perform her last year of training in the Builders Olympic Games symptom free, and she was away. So if we use respiratory muscle training in the right context with the right kind of idea around what a good breathing pattern is, it can be really powerful. I mean, this is obviously an example with an elite athlete, but we kind of use this with kind of recreational athletes and with patients as well. I'm going to hand on to Kris about kind of just talking about some of the developments that he's doing as put sort of some of the latter stages of his PhD into this sort of area.
Yeah, that's great. Thanks, John. So I'm just going to continue kind of the theme really, but really focus a little bit more on the inspiratory muscle training side of things. So I mean, I think it's pretty clear from lots of the evidence that IMT is used in a variety of cohorts and many different populations, and demonstrates gains in a number of different outcomes depending on what that population was. But I thought it would be beneficial really just to pop up this graphic, which was taken from Francesco Ferraro's recent paper, which kind of summarizes some of the training protocols used in IMT training. Now here they outline that most of the studies converge on MIPS of around 50%, 30 breaths twice a day for 6 to 8 weeks. However, as they highlight and as I've kind of seen as well, there's quite significant heterogeneity in lots of the published studies. So, if we think about a range of the IMT studies that are out there, we can see MIPS of between 20 and 80% used. We can see training regimes occurring once or twice a day. We can see them occurring 5 to 7 times a day for a matter of minutes to half an hour for 6 weeks to 12 weeks. So there's a really big variety in kind of what's happening out there. Now, a question that I get asked quite a lot is, why do we do the 30 breaths kind of twice a day? And that is a commonly used protocol, and it has been demonstrated to be effective. And that kind of regime was developed and evaluated through the experimental work of Professor Alison McConnell and her colleagues. And that was based really from Loughborough universities and Brunel and Birmingham University as well. But since then, there's been lots of established use of it in peer-reviewed research and published articles. Now, what their studies have shown is actually loads of around 50% MIP actually demonstrates kind of optimal muscle activation. It shows kind of inspiratory flows, optimal inspiratory flows, power levels, and lung volume levels. And actually, you know, working at around about those loads enables people to keep training for around about 30 breaths. So they've got a 30 breath maximum for that. In terms of twice a day, you know, that's probably likely due to the fact that that enables an appropriate training at a sufficient intensity and load, so as not to cause chronic muscle fatigue. So the evidence is there in terms of why that protocol is used. Now, in a kind of study at the University of Kent, where we are here, we've kind of looked at characterizing IMT breaths in cohorts who've got a breathing pattern disorder. And actually here we saw that the power curve provided quite a unique insight into some breathing evaluations. If we actually look at what the power curve can offer, and I'll talk and give some examples in a moment about that. And if we apply that to some of the general principles of IMT training, we know that if we look at a power curve, it will enable us to evaluate whether somebody is using the full range of their lung volume. It will tell us whether somebody's given us a maximal effort or a good effort. And it will give us an indication as to whether there is an appropriate loading to their training breath. And all in all, it will help us to evaluate their breathing technique. Now, these are curves from the same individual, and what we noticed is that at higher MIP levels, breathing technique was more variable. It was more compromised, and it demonstrated this pattern of peaks and troughs. There was a massive reduction in volume, although it might not be completely obvious on here. The volume is reduced. And that suggests to us that there was poor coordination, inappropriate loading at some of the higher MIP levels in the population with breathing pattern disorder. And actually, we saw this at MIPs of at 50% of their maximum, so we can see quite a disrupted peak and trough to their power curve, even at 40% MIP and at 30% MIP. So if we look at initiating a training regime at 20% MIP, we can actually see that the power curve here is a lot smoother, it's much more coordinated, and actually they're tolerating that load a lot better. So in this population, it has led us to initiate training regimes at kind of a lower starting load. Now, what we've also been able to do here is, in conjunction with working with POWERbreathe, to develop a first stage training curve which utilizes the power curve. Now, this is currently under evaluation at the moment, and we can share some data kind of as and when we're able, but I just wanted to highlight that at the moment. Now, in terms of breath insights, using the power curve to kind of optimize technique is something that we do quite a lot here at University of Kent, and the curve on the left-hand side is an example of what we consider to be a good technique. The green curve there is what we consider to be an ideal curve. So we can see actually with somebody that's got a really good technique and appropriate load, we're getting really good power levels and power curves and good lung volumes. Now we can evaluate that as well. So somebody who's given a poor effort, again, is not going on the power curve, it's not going to achieve significant increases in their power. The curve is going to be very much reduced with very much reduced lung volumes on there as well. So we can really utilize that to have a look at their technique. What we've also noticed on the power curve as well is that for some individuals who are overusing their shoulders or their accessory muscles, they tend to get this very rapid kind of rise in their power curve, which provides a very kind of rapid peak, and then it tails off quite quickly and quite rapidly, showing a reduction in volume as well. We can also see that somebody who has a poorly coordinated technique shows this kind of pattern of peaks and troughs on their power curve as well. And that can be with adequate lung volume, or it can be with reduced lung volume. It can even be at higher power as well. But what we do notice is this disrupted peak and trough kind of appearance to the power curve. Now, this example here as well gives us an example of somebody who's got quite a poor coordination of their technique, and also an abrupt end, so they're not fully completing that breath, it's stopping. And that's all information that we can kind of gather from utilizing and evaluating the power curve. And again, here we've got an individual who again is showing a poor coordination of the rib cage throughout their technique there, but also a delayed peak to their power curve, which might mean that they're not kind of generating sufficient kind of speed and power initially in their breath. And again, we have a delayed peak to the power curve here, which again may signify that the individual isn't taking a fast enough or a powerful enough breath in at the start of their technique. So actually using these insights, technique can be optimized using the power curve, and that's whether that's by improving postural support during training that we give participants, or modifying that, whether that's on working on releasing tensions around shoulder, neck, upper chest, whether that's by encouraging a faster, smoother breathing pattern and inspiration, whether it's encouraging individuals to fully empty their lungs or fully inspire, and also to kind of establish an appropriate load as well. So actually utilising the power curve in this setting has proved quite valuable for us here. Here's an example of some... Oh, need to click on it?
Yeah.
Here's an example of the power curve. You can see actually now
Really good.
From underneath there, where there was a bit of work that we needed to do in terms of encouraging an improved technique, just in terms of delivering a fast, smooth, powerful breath in there. In terms of our experience here at the University of Kent, and in particular with people with breathing pattern disorder, we do utilise the power curve a lot, but that's not to say that you shouldn't be reviewing the other curves as well. So do look at your load, your flow, your volume curves as well. It's well established that 30 breaths twice a day is generally an effective regime. So we do use that. What we do tend to do for some individuals, we may need to break that 30 breaths up and build it up. So you know, it might not be that somebody can complete 30 breaths all in a row straight away. It might need breaking up into, you know, 3 lots of 10 or 5 lots of 6, and kind of slowly building up. For this particular patient group, we've seen that starting with a lower starting rib tends to be quite useful, with a view to being able to build that up once the technique is there and established. We tend to increase progression by around about 10% increments, and ensuring that participants can kind of take 30 breaths in a row before we would start to progress their IMT loads. In terms of reassessment, obviously that's really important as well. We would keep an eye on people's MIPS, we would observe their breathing pattern, and do a lot of video recording as well, so we can kind of gauge any difference that's been made. Obviously, we would want to consider, once we've established a good IMT protocol in place, thinking about altering the position, posture, activity that somebody does that in as well, to get the, you know, to see if we can progress the benefits of that. So there's lots of kind of things that we've been doing which have utilized the power curve here at the University of Kent to improve or help guide us to evaluate breathing pattern.
Super. So probably just to kind of wrap up the kind of presentation, and we're really happy to kind of take any questions. Just to sort of summarize, the breathing pattern is a kind of bidirectional whole body system. So it's more than just breathing in, breathing out. Obviously, there's the rate, there's the depth, there's the rhythm, there's the mechanics, there's the neural drive, and they're sort of shaped by the kind of 6 physiological systems that feed into it, and also the breathing pattern will then impact those six systems. So it can be quite complex, and sometimes when there's alterations to breathing pattern, it's not always the same system that's causing maybe breathing pattern to be less efficient. But just be quite holistic when you're thinking about breathing pattern. If you're going to kind of, what I think hopefully has come through here is that if you're going to use respiratory muscle training or inspirational muscle training, think about it as you would for any other kind of strength training activity. So, if you're walking into the gym and you were doing your squats, you're going to make sure you want to kind of do those squats with resistance, with good technique. Now, you can maintain good technique until a point comes where you put too much load on the bar, and then your technique starts to waver, and then that potentially then starts to train poor movement patterns. The same thing can happen with IMT. So it's important that when we're using respiratory muscle training, although a lot of the studies do kind of go with that 40 or 50% of maximal mouth inspiratory pressure, that might not always be appropriate to start with, but maybe to work towards leading up to it. So do be aware of the load and how the load might impact technique. My general thought process is start lower than maybe you need to, and build, make sure the technique's there before you kind of add on, kind of get to maybe target kind of intensity. And if you are able to use things like kind of the K series, those POWERbreathe kind of power curves are really good at helping kind of guide the quality of the breath, as Chris has shown. They can be quite intuitive around it in individuals using maybe too much apical movement or too much shoulder movement, or whether they're asynchronous, so the movement of the torso isn't together, or if for example their movement's okay, but they can't finish the breath off. So there's lots of things you can pull out of those curves that can really be insightful to help kind of maximize the training that an individual's doing. And this is kind of across all kind of users. So whether you're an elite athlete for down to kind of a respiratory patient, they are the same principles regardless of who you're working with. But anyway, we'll stop there. Me and Chris talking. Very happy to take questions. So
Thank you, John and Chris. That was honestly wonderful. John, you finished with a really nice explanation of the analogy dumbbells for your diaphragm, which I think explains the concept of respiratory muscle training really well. But as you say, it's technique first and then build up with that load. And Chris, your PhD is fascinating. As you know, I'm really enthused about it and look forward to seeing some more results. We've had some questions, but I just wanted to ask a couple first myself. The first one I wanted to know, just out of interest, is do you see breathing pattern disorders more commonly in any particular cohorts of people? I'm just wondering if there are any sports where breathing pattern is more prevalent, or perhaps patient cohorts.
do you want to go first, and you can
Yeah, you go first.
So there's probably, in terms of research wise, there's probably not enough research done in terms of kind of looking at prevalence in different cohorts. But from my experience, we tend to see more, if you're looking at athletes, tend to see more female athletes report than the male athletes do. We tend to see more athletes from endurance and sometimes repeated sprint sports kind of present with symptoms, which kind of makes more sense because they're the ones probably pushing their respiratory system or more reliant on their respiratory system. Whereas if you're working with a power athlete or a sprint athlete, they don't necessarily need to breathe so much, so they're not so worried about their breathing pattern. And again, from a patient cohort, A lot of people with kind of long COVID symptoms kind of have symptoms of kind of breathing pattern disorder. Approximately 30% of asthmatic patients have a breathing pattern disorder. And then you've got the similar kind of thing with COPD. A lot of other cardiovascular diseases have it, but one of the problems with the diagnosis, well, with knowing that prevalence truly, is a lot of this is kind of based on symptoms rather than confirming the breathing pattern disorder. So it's quite difficult to really hone in why those sort of people are reporting or presenting more with breathing pattern disorder than others. I don't know if Chris wants to add to that.
Yeah, no, I mean, I kind of agree with that. In terms of kind of prevalence, it is a bit of a tricky one because, as John kind of mentioned, because there's no real diagnostic framework, it's quite hard to actually get a definitive kind of number. If you look at the research, then, there's a general prevalence reported in the general population of around about 10%. So that's, in individuals who have, no other real kind of cause for a breathing pattern disorder it's there. We do know that the prevalence is increased if you do have a respiratory disorder. So as John mentioned, if you've got asthma or COPD, the prevalence tends to increase, particularly if you've got difficult or poorly managed disease as well. We see a higher prevalence as well being reported post COVID. There's also some increased prevalence in anxiety related disorders as well. So, there are certain kind of cohorts who have a tendency for a higher prevalence, but the actual quantification of that is a bit tricky.
Okay. That feeds in quite nicely in a way to the next question. You mentioned a lot whilst we've got OEP for the diagnosis, a lot of it is based on symptoms. We've had one question, which is if we don't have access to visual feedback, for example, with the K series, where you can look at the power curves or the flow volume, what should people be looking out for in terms of getting a good breathing or IMT technique, and when should they consider reducing the inspiratory load?
Yeah, I think that's really good. So if you're using like a pressure threshold device, so a few things you can do. One is to obviously rely on the feedback if you're using it yourself, or rely on the feedback from your patient in actually asking them, do you feel you're actually getting a full breath for a start? Because some people might go, well, I get half a breath and then it stops. So that's one of the feedback. The other one is to actually listen to the air going in. So if it's kind of a consistent sort of, that would suggest the breath is nice and smooth. Whereas if the individual's kind of, and there's variation to that noise going in, you probably like to see that kind of variation in the flow, and that can sort of demonstrate potential asynchrony and difficulty in keeping the valve open. So you can listen, you can use your ears and listen. The other thing is to observe. So if you're watching them, you'll be able to see kind of maybe jerky movements sometimes, or inconsistent movements, or kind of a lot of using the shoulders to try and get that valve open, which can be another sign that the valve's a little bit too high. But it's important to listen through the whole of the training session, because as they get more fatigued, there's a higher risk of those things kind of creeping in. So you can do it without. The other probably thing you could do is also video it. If you're not quite sure, if you don't want to kind of try and pick up all of those things all at once, you could video them doing it, or ask them to video themselves doing it, and then they send it in. And I work with a lot of my clients that I work with. I ask them to video their sessions if they're using especially if using the pressure threshold devices, and then we can kind of work out whether that's an efficient session or not based on what I hear and see on the videos.
Mhm.
Yeah, and I'd add in as well, really use your skills of observation as well, because you can see where somebody's initiating a breath from. You can look at where their rib cage is moving from as well, by looking. And also if they're overusing, their accessory muscles or their neck muscles, and just have a look at kind of what they're doing during the training as well will give you a lot of information.
Mhm. Somebody's asked whether you are currently, or essentially they've said when you're looking at the curves on the K series, can you assess or triage for things like ILO, and have you seen any differences between the curves? I know that you're work Kris has focused on breathing pattern disorders specifically.
Yeah, I mean, my research here has focused specifically on that. I don't think there is any kind of research out there, correct me if I'm wrong, John, that's looked at whether it's helpful in terms of diagnosis of ELO.
Yeah, no, there's not really. Partly that's down to the flow rates that individuals probably get when they're actually doing the power breathe. The power breathe itself almost acts like a bit of a breaker, so the air flowing through the upper airway doesn't necessarily replicate the speeds that the air's flowing when the kind of ELO kind of starts. So unless you got really severe ELO, you're probably not going to see any kind of flickers on the power curves. I certainly haven't in my kind of my time using it with individuals with ELO. Um, so yeah, it's not really a tool for that. But that said, we do use RMT a lot with individuals with ELO because it does help with that kind of conditioning of the upper airway as well. So it does help condition the kind of muscles around here. And anecdotally and also in the literature, there's quite a bit of evidence now to suggest it is a helpful tool to train with individuals with ELO.
A little bit of a spoiler alert, I have got a talk on this coming up later in the series, so hopefully that will answer some of the questions as well. Thank you. Somebody's asked, when you're analysing breathing mechanics using the reflective markers, the OEP, have you done any investigation looking at breathing patterns during progressive exercise protocols, for example, VO2 max testing?
Yeah. So some of the research I kind of quoted there, we've not necessarily done it all the way through a full CPET, but what we've done is we've kind of done it at kind of a low intensity exercise, mid intensity exercise, and a high intensity exercise. So we kind of know what a good breathing pattern is at rest, at light exercise, at moderate, and at heavy exercise. But it pretty much keeps true to those kind of key things that I was talking about there about where the breath was initiated from, the movement continues all the way through from kind of movement in the lower rib cage and it radiating into the abdomen and into the upper chest. So the movement pattern doesn't necessarily change too much as you increase intensity of exercise. It's just how much of that rib cage moves does. And obviously, as you get closer to that kind of high end exercise, the breathing frequency increases more, as well as the volume of the as well as the kind of the movement mechanics of the rib cage as well. So we've done that. If they're interested, I can, they want to get in touch, I can ping them the actual reference the paper that demonstrates that.
Thank
And
you.
actually, part of my PhD, we've looked at OEP at rest in individuals with breathing pattern disorder. And actually, we've looked at exercise as well at 30, 50, and 70% of their VO2 max workload. So hopefully, at some point, there might be a bit of research coming out on that.
I think that answers the next question, which was power curves and correlation with CPET findings. So we'll keep an eye out for your results, Kris. Thank you. Are there any precautions we should take when introducing IMT in asthmatics with optimal control? I don't know, John, and Kris, you've both had experience dealing with patients with asthma.
Yeah, I mean, I think once a patient with asthma has got kind of optimized control as far as their kind of inhalers and their exacerbations are concerned, it really is almost sort of like it's like introducing RMT to anybody else, really. But I think the key things are don't start too high. There's no danger in starting at a 20% resistance and building up from there. So I would just build it in nice and steadily. Focus on good sort of inhalation technique and nice relaxed breath out. I mean, the only probably dangers to maybe be aware of, obviously, because you're asking them to breathe in through their mouth and just be aware of the environment that they're in to make sure they're not in a particularly dry environment or in an environment that might have a lot of asthma triggers for them. So maybe just be a little bit aware of that. But other than that, I can't think of anything. I don't know if you can think of anything.
No, if the asthma is well controlled, then it would be the same precautions and contraindications as you would use for any individuals. There shouldn't be any specific ones to be too concerned about.
I was going to say the same as Kris. Somebody's asked that they've said there appears to be little documentation on long-term effects of IMT upon resting and exercise breathing pattern. and if the frequency or depth trends change throughout an exercise before and after IMT. Do you have any insights on this, is what they've asked.
I mean, so I think
Judge
it's a
question.
limitation of a lot of research out there. There's a lot of
Yeah.
research. Their interventions only go for sort of 4 to 8 weeks. And the breathing pattern can, as much as we retrain individuals' breathing pattern can go the other way. So just because you've changed your breathing pattern and made it more efficient doesn't mean it can't reverse and go back into an inefficient breathing pattern as well. So there's no, I wouldn't say there's a ton of there's any data out there that looks at the kind of how long do these impacts of improving breathing pattern last for once you've undertaken a course of breathing pattern training or respiratory muscle training. But there's as with any kind of change in technique of anything, it can reverse itself and become less efficient. So, I mean, I think it's a tricky study to run, be a very longitudinal study, but maybe people can kind of do some studies, maybe something we do with Chris's cohort in a year's time and check in with them, get Chris back in, and he can kind of retest his participants who've been going through his studies and look at kind of how they've been able to hold on to their kind of breathing pattern changes, have they been able to hold on to their adaptations to their respiratory muscles. It's a really good idea for a research project.
There you go. That's your next one, Chris.
Yeah.
Are you okay for just a couple more questions?
Yeah,
Yeah,
yeah.
yeah.
Has there been any work done on the coordination of the pelvic floor alongside the diaphragm and abdominal movement in breathing pattern? Obviously, we know that there's synergy in breathing. We've had a previous presentation on that, but is there anything specific to breathing pattern?
Not that I've come across. Have you come across anything?
No, I haven't. But again, that makes perfect sense
Mm.
to look at the two because of that kind of, the synergy that exists there. But I can't from the top of my head think of a direct study that has kind of looked at that.
Yeah. I mean, what I would say is if in a sort of practical context, when we're teaching breathing pattern, well, a lot of kind of what I try and get individuals to do is really kind of focus on where they're holding that postural control, i.e., really it should be around that kind of pelvic kind of area, so it frees up the respiratory muscles to do the movements they want to do from a respiratory point of view, rather than contributing too much to the postural control. So having that kind of postural awareness, if you want to call it that, um, or another word anyway, postural literacy. It's definitely something to teach alongside it. It's a study I've actually wanted to do for a while, looking at kind of postural control and movement of the rib cage. It's just very difficult, without putting lots of invasive things into people, about looking at kind of the control of these muscles because they're quite deep seated
Mhm.
muscles. But it'd be a really interesting study again.
As you said, I mean, the theme across a lot of these webinars is that there's sufficient research to support IMT, but there's so many more topics that we would like to research to hone down protocols or conditions that it could most benefit. And actually, it was Jessica DeMars that spoke about pelvic floor dysfunction, and that was kind of the theme of her webinar back in April. If anybody wants to go and have a look, there is evidence, but as John has just said, we need more research before we can really say how best to use IMT and how it works. Um, there's one more question. I don't know, Chris, if you would be able to, I don't know if you have any insight on this. They're asking about the POWERbreathe expiratory muscle trainer and if you've had any experience in clinical practice, and does it play a role in pulmonary rehabilitation?
Yeah, I mean, I haven't actually used it directly myself. I know a lot of the evidence around the expiratory muscle trainer is in kind of like speech and swallow dysfunction. And I know there's some really, really good evidence that have shown benefits in terms of outcome measures in that area. Um, so I don't know is my answer to that one.
There is a lot of, as you say, I've recently read some papers even in the past week about pulmonary rehabilitation and actually indeed prehabilitation, both utilizing IMT and EMT. It depends on the cohort of patients and their biggest their biggest need, essentially. Both often play a role. And the EX1, the POWERbreathe EX1 is a threshold trainer, just like the inspiratory muscle trainers. So it utilizes the same spring-loaded or calibrated spring-loaded valve. So it's certainly a good means of providing that expiratory resistance in the right people. I don't know if I've lost John and Kris.
No, we're there. We're just very still.
I've stunned you into silence. Pulmonary rehab and prehabilitation is indeed a topic, a whole other topic for another day. I think that is we're going to end there because the last question is actually a comment and somebody's just said phenomenal presentation, which I completely agree with. So thank you both so much for your time and your insightful presentation, and Kris for sharing the preliminary results or take-home messages from your PhD, which I'm really excited to hear more about, and I hope that we'll be able to get you back on the Better Breathing Institute so that you can present your findings perhaps sometime next year.
Absolutely.
Thank you very much.
Thanks for having us.
Thank you.
Have a good day. Thank
Cheers,
you.
thanks.
Bye. Bye.
Bye-bye.